OR Manager is pleased to welcome you to today's webinar, The Modern Hospital Operating Room, Overcoming Obstacles to Organizational Transformation, presented by Surgical Directions, a leading healthcare and perioperative consulting firm. My name is Iris, and I'll be the facilitator for today's event. I would like to formally welcome all the attendees joining us today. Please note today's call is being recorded. This presentation will last up to 60 minutes and will include question and answer opportunities at the end. You may submit a question at any time by typing into the chat box in the lower left corner of the screen and clicking the send button. It is now my pleasure to introduce today's speaker. Dr. Tom Blasco is a practicing board-certified anesthesiologist, intensivist, and a medical director with Surgical Directions. He also serves as the medical director at the Illinois Sports Medicine and Orthopedic Surgery Center. Dr. Blasco works extensively with hospital surgical and procedural departments to improve financial performance, operational efficiency, and organizational effectiveness. Dr. Blasco has been instrumental in the development of several freestanding, physician-owned outpatient surgery centers, including the Chicago Prostate Cancer Center and the Illinois Sports Medicine and Orthopedic Surgery Center. Additionally, he has held academic positions at Northwestern University and the University of Chicago. Dr. Blasco, welcome to the program.
Well, thank you very much, and good morning, everyone. I'd like to begin this introduction by basically saying that most of my career has been within the modern U.S. Hospital operating room, as well as the intensive care units. And just recently, it's kind of parallels the transformation of surgical care in the United States. I've spent a lot of time building and operating freestanding outpatient surgery centers. So I have gone through the transformation in my career that most of the hospitals and U.S. surgical care is going through. So this is a presentation that talks about the modern U.S. hospital operating room and its current dilemmas in trying to adapt to the current expectations and demands of the U.S. surgical care system. And it's about how to overcome a lot of the long-standing obstacles to organizational transformation. The presentation will be divided into a number of parts. First of all, this is part of the introduction. We're going to get into the two major obstacles that I think are at the root cause of the issues related to transformation of the U.S. Hospital operating room. And then we're going to get into the surgical directions system that's been developed over 21 years of overcoming these obstacles and producing a streamlined, well-run, high-value, high-satisfaction surgical operation. I think we should start to talk a little bit about the breadth of competencies that exist within surgical directions. And this has taken us just about 21 years to get to this point. We've added certain elements of our consulting approach over the years, but it's everything. We basically address everything from the time that the surgeon picks up the phone to schedule a case to the time the patient's discharged from the recovery room and even farther out, for example, the ICU and on the floor. It includes clinical redesign, strategic growth initiatives, surgical scheduling, physician relationship, patient throughput, and on and on and on. So it's a very broad-based approach, as you're going to see today in this slide presentation. We have a lot of potential interventions that can occur as a hospital tries to transform itself. I think we have discovered over the years that the most important key drivers of success, and there's 6 here, but I'm going to just talk about 2 in particular. Physicians have to begin to take leadership roles in this transformation. For the last 100 years, and we'll get into this in a few minutes, physicians have largely, and that includes surgeons as well as anesthesiologists in the operating room, have taken largely a very distant approach or no approach at all in terms of driving change. The other major area that has to be addressed is the area of predictive analytics that drives change. I think most hospitals now are required to have information systems. These are very robust, but we're just starting to get into the predictive analytics that can really identify issues and also drive change. So, this is an old slide from Surgical Directions, but it says two important things. First of all, in the U.S., the modern hospital operating room generally drives most revenue within the hospital. For example, I come from a hospital that has approximately a $2 billion a year income. And of that $2 billion, probably $1.4 billion comes from procedural services and most of the profitability. However, and this is also the dilemma that occurs in the United States, the culture within the modern U.S. hospital operating room has changed very little in over 100 years. This is you see on the right a very famous painting, the Agnew Clinic. And basically, although technology has changed, the culture within the operating room has remained relatively unchanged. Layer on top of that the fact that the government and multiple different organizations are basically measuring care, measuring quality, measuring efficiency, measuring productivity at a very granular level, putting the hospitals now under a microscope, especially their operating rooms. Also, the payment mechanisms have changed from traditional fee-for-service, which was a very simple way of paying for care, but it also caused a significant and never-ending increase in the cost of surgery without much restraint. Interesting slide here, and these are all real-life examples from some of our clients, but to really overcome a lot of the cultural issues that are preventing change, you really have to start driving change from just a rudimentary perspective, and that includes just first case on-time starts. How do you, the traditional U.S. hospital typically has anywhere from 30 to 40% on-time starts. That's the wheels in of the first case. What we see here is a hospital that we had an intervention in. This hospital was in the Midwest. When we started the project, the on-time start rate was 40%. The hospital was ranked 15th out of 15 hospitals in the system. By the time we finished the project, you can see they approached 90% on-time starts, and they went from 15 to number 1. Another area of intervention is delays and cancellations. You can see in this particular hospital, this is another hospital, we went from a 12% cancellation rate within 24 hours of surgery down to a 7% cancellation rate. And their day of surgery cancellation rate dropped from 5%, which you don't see here, down to less than 1%. This is, again, an interesting slide, but the pictures tell 1,000 words. This is a hospital in upstate New York, and you can see on the left, this is between total knees, total joint replacements. You can see a person bagging garbage. This happens to be a this particular person has a Master's of Science in Nursing. She's the clinical lead of orthopedics, and she's bagging garbage within a turnover, and there's no one else in the room. This particular turnover took nearly an hour. The same operating room, approximately 8 months later, we had rechoreographed a parallel process turnover, and we went from over nearly an hour of turnover time to approaching just 10 minutes between joints. You can see it's a highly different scenario, but this is what is necessary to bring about significant U.S. hospital organizational transformation. So we've talked about, I think, the goals of what we'd like to reach: on-time starts, expeditious turnover times, great patient care. We'd like to have it physician-driven, based on current and accurate and vetted analytics. But what are the obstacles besides the culture? And it is the culture. Surgeons and physicians in general are not taught to be team players. They often have a very distant relationship with hospitals. You know, recently there's been an ongoing trend to employ physicians. It was a method that was supposedly going to now create a much more cohesive and collaborative relationship between hospitals and physicians. It's occurred somewhat, but we're still a long way from having a good collaboration between physicians and hospital leadership. In fact, this slide I think is kind of interesting. I copied this from a recent lecture I was at. This gentleman is a organizational change expert. He's an emergency room physician on the West Coast, but change is good, you go first. That's basically the motto in the modern U.S. hospital. So the culture is entrenched, and the culture within the U.S. hospital operating room is very unique. It's very unique compared with any other place within healthcare. There are 4 agendas when you walk into a U.S. operating room. There's surgeons, there's anesthesia providers, there's nursing and staff, and finally there's administration. And it has not changed in over 100 years. You ask surgeons around the country, when I need a room, I want to have a room available to me. Anesthesia would like to have a busy day that's filled without a lot of gaps so they can be highly productive, but they really want to work only during prime time and not be kept in the hospital late at night and on the weekends. Nurses are hourly employees. They want to have their breaks and their lunches, but more importantly than that, they want a predictable day. The most disruptive event that can occur for most nursing staff is when somebody walks into an operating room and said, could you stay for another couple hours? We just don't have the staff, and we need you to stay. Again, this is probably at the root of a large amount of the high nursing turnover that's occurring in current U.S. hospital operating rooms. And finally, because the operating rooms are so financially powerful, the administration would like to have operating rooms running 24 hours a day with well-paying patients and without overtime. It's a dream that's never going to come true, but that's what they would like. To put it into realistic and very, very practical terms, if you look at hospital operating rooms, the productivity, the ideal productivity varies with the four agendas. The first one is administration. Remember, we said that the administration would like to have the operating rooms very, very busy 24 hours a day. So they would like a utilization or productivity that's approaching 100%. On the other hand, and we've been in hospitals like this where the surgeons are calling the shots and determining OR usage, a typical hospital room that's surgeon-dominated will have a productivity that approaches less than 50%. And so, to be honest with you, the surgical directions methodology, and we're going to say this over and over again, is balancing the surgeon's need for access versus the hospital need for productivity. And so it's somewhere in between. So it's not going to be 100% or less than 55%. A reasonable productivity in the operating room would be about 75%. That means that the surgical minutes in an operating room, let's say it's 8 hours, plus the turnover time, is greater than 6 hours. The other obstacle, and this is a profound and very common issue within most U.S. hospital operating rooms, is ineffective leadership model. A typical U.S. hospital operating room, by default, has a nursing director who's managing operations pretty much by his or herself. And it really is an ineffective model because when a surgeon or an anesthesiologist or a nurse walks to this administrator and says, I need something or I want something or something's happening, if she can't immediately address the problem, this person, especially the surgeon, will go immediately to the hospital administration, which is fearful of losing the surgeon's business, and in many cases will say, just fix it, whatever it takes. So this leads to Band-Aid approach to managing an operating room, and surgeon access starts approaching 50%. There typically is very short release times in the schedule. There's no proactive schedule management. There's lots of staff turnover because the operating room is pretty much very inconsistent in how it's being used, and there's huge variations in demands of the operating room staff. So the two major obstacles are culture and leadership. And Surgical Directions has spent approximately 2 decades in trying to find the best approach to overcoming these issues and providing and allowing the hospital to compete with the rest of the market. Of interest, I think this is an important statistic, in the current U.S. procedural market, there are approximately 60 million procedures done a year. Of those 60 million procedures, only 10 million remain in the hospital overnight. The rest are either done in the hospital, in ASCs, or in the office, in the surgeon's office. This is a daunting change, a daunting task to address these changes in this out-migration. And we have started this organizational transformation by installing in many hospitals, and we've been in hundreds of hospitals around the country, a radically new and different leadership model. We call it the Surgical Service Executive Committee. You can call it the Surgical Operations Committee, but basically it's made up of 4 groups: surgeons, nurses, anesthesia, and senior hospital administration. I'm going to stress senior hospital administration. Typically, the usual committee that's physician-based within the hospital is the surgery committee. This is typically a medical staff committee. It's typically not well attended. Hospital leadership generally does not attend either, and it's relatively ineffective. What we suggest and what does work is that we actually encourage senior hospital leadership to attend. The committee is owned by the administration. It's not a medical staff. It becomes literally a board of directors of the operating room, and it's chaired by, for the most part, 2 medical directors. One is a surgeon, one's an anesthesiologist. And it controls all operations. Let's go to the next slide here. And a typical SSCC, or Surgical Service Executive Committee, is in charge and has leadership and sponsorship and authority over all aspects of perioperative patient care. It also has direct oversight over nursing, leadership, medical directors, and business managers. And it's responsible for everything from the time, again, the surgeon picks up the phone to schedule a case to the time the patient's discharged from recovery room. It thrives on accurate data analysis. It's involved with strategic planning and business development. It's truly a board of directors. This is an actual Surgical Service Executive Committee. The names have been changed, obviously. This is a hospital in Florida. I want you to notice a couple things. First of all, the CEO of the hospital attended and has attended every single SSCC, and he continues to attend 7 years later since we've been there, as well as the chief nursing officer. There are 2 medical directors. One is an anesthesiologist. One is a general surgeon. Generally, the surgeon runs the committee, and we'll talk about the role of the anesthesia in just a moment. But what's even more important is that the dominant number of participants are surgeons. We insist that however large the SSCC is, and it usually is less than 15 to 20 total membership, that more than half the membership are surgeons, and those surgeons have to attend. What's also interesting is that once the CEO is at the table, and once we start talking about surgeon access and patient throughput and frontline operational management, the attendance by surgeons skyrockets to nearly 100%. And I've not, in 20 years, I think there's only been 1 or 2 hospitals where attendance was problematic. Most of these committees are incredibly well attended because there's lots of decisions made on operating room operations that affects the surgeons directly. This is the most important vision and mission of the SSCC, balancing the surgeon's needs for reasonable access, efficiency, safety, and quality care versus the hospital's need, of course, for great patient outcome, but more importantly, OR productivity. accurate data drives, and we'll talk about this a lot near the end of the presentation, accurate data, vetted data drives a lot of the decision making. And the issue that has occurred for just about in every hospital for 100 years, I'm going to take my patients and go to another hospital, is largely eliminated by an effective surgical services executive committee. Okay. So the governance goals are pretty simple. First of all, you want to improve both surgeon and patient satisfaction. I'm going to say this to the people on the line. You may not agree with me, but the true customer of a hospital operating room is the surgeon, and great patient care is the product of what you're trying to produce. So you really want to, the goal is to obviously improve performance, productivity, efficiency, and quality. Of course, you want to develop quality metrics that drive change, and you want to obviously have positive financial results from this. So we start with leadership. So we talked about the SSCC. The next level down is the improved operational or frontline management. The typical, as we said before, the typical hospital operating room is managed by a very active nursing director with her nursing managers and team leaders. However, this approach has been replaced by us by a joint leadership group that includes nursing directors and managers, as well as a focused and dedicated and collaborative anesthesia leadership team. And this is where the anesthesia co-medical director largely functions as a frontline leader in operational management, collaboratively working with nursing leadership. The most important area in frontline operational management is the institution of a daily huddle. This huddle is multidisciplinary. This is a hospital I think we're working at currently. In fact, I was there last week. And this is the daily huddle. You can see representatives from anesthesia, operating room nursing, pre-admission testing, scheduling, sterile processing, material management. There's a conference call in process with multiple people on the call listening in and putting their 2 cents in. But basically, this particular committee meets at 12:30, just prior to, actually the slide is wrong, just after the closing of the next day's schedule. And it reviews the schedule from a multidisciplinary points of view, at least 3 days out. We encourage actually 5 days out, but at least 3 days out. You're identifying problems and opportunities and scheduling changes early before the day of surgery, avoiding a lot of the last-minute cancellations, delays, and craziness that occurs in the typical U.S. hospital operating room on a daily basis. Another key in this frontline management is you have a much closer relationship with the surgeon's offices and their scheduling and their scheduling practices. A good relationship between the hospital operating room and the surgeon's office will make for much happier surgeons, patients, and a much more efficient process. The final area, so we've talked about leadership, management, and now we're going into performance improvement teams. This is the complete pulling apart of the organization, and it starts from the ground up. We have these multidisciplinary groups. This particular group was sterile processing, and each area that we've talked about here, optimization of efficiency, which is basically on-time starts and turnover times, PAT and scheduling, patient preparation and scheduling, anesthesia work group, sterile processing, nursing leadership, physician dashboards and scorecards. These are just some of the performance improvement teams that we will institute during an organizational transformation process. But again, they're collaborative, they're supported by the SSCC, and their decisions and their process are transmitted to the entire operating room. We usually use a lot of pilots, and they're very effective in getting the bugs worked out before we move it to a system-wide approach. We also have town halls with the surgical schedulers at the various surgeons' offices. We talk about all the changes, but it's a very collaborative process, very effective, and if properly run, we use lean approach to a lot of the stuff, and it's very effective. This is an example of the efficiency task group at a hospital, and it's an example of a first case on-time start timeline. And as you can see, and this is based on the decisions of the group, with surgeons, anesthesia, nursing leadership, everybody else putting their 2 cents in, we have a very defined timeline of how we get a patient into the room on time. I've highlighted in red the surgeon's expectations, and we expect to get a 7:30 wheels in time, to have the surgeon signing off with all of his H&P update, his consent, site marking, and patient discussions at least 10 minutes prior to the movement of the patient into the operating room. This is we've done this in multiple hospitals. The key is there's a number of interesting aspects on the first case on-time start. The first one is that for a surgeon to begin to change his behavior, you have to get your house in order. In other words, the OR staff, the anesthesia staff, and patient preparation and scheduling have to be completed by approximately 7:10 in this particular model. Everything has to be done. Then you can hold the surgeon accountable, and generally 80% of surgeons will start coming on time if you have your house in order. We showed for that one demonstration, you can go from a 40% on-time start rate to greater than 80% on-time start with this type of an approach. This is another area of particular interest for surgical directions. That's optimizing patient preparation. In my personal hospital, in which we perform approximately 40,000 procedures a year, when we first started this 20 years ago, we had a 5% cancellation rate and it was almost 20% delay rate of our cases going into the operating room. We decided, using the Cleveland Clinic model of patient care, this Cleveland Clinic model sees approximately 4,000 patients a week. We decided to centralize and carefully provide careful oversight into a centralized, common approach to patient preparation, including, you can see here, laboratory algorithms that we expect all of our patients to go through, whether they're seen by a primary care doctor or go through our pre-admission testing center, but with a carefully constructed process of patient preparation and with a timely intervention of our pre-admission testing center into the patient's preparation process, we have reduced our cancellations from 5% to less than 0.5%. And our delay rate is now down less than 5%. So moving from the surgeon's office, which typically controls a lot of patient preparation and laboratory algorithms, we've moved it to a single central authority that provides everybody with this resource that they can use for patient preparation and reduces a lot of delays and cancellations. The final area we're going to be talking about today is data drives change. This comes out of a university hospital in New York. It is a report card that's sent to surgeons every month. It's incredibly detailed. I'm going to show you. It's actually 2 pages. And I'm going to go back to the first page. But it's everything from how the surgeon uses his operating room to how much of his time, how much of his block is actually used, whether it's appropriate utilization or either under or over utilization, what his delay rate is, what his costs are, how he stacks up with his peers for similar types of procedures. It's incredibly extensive. Most report cards that we produce for surgeons are not this extensive, but even a full page of data in terms of how they use the operating room and how their patients are what their outcomes are, and how they stack up with their direct competitors or similar procedures is incredibly powerful in changing surgeon behavior and actually implementing a more responsible use of the operating room. And this is another slide that talks about the costs that are sent to surgeons for their total hip replacements. Again, this is the same hospital in New York. But you can see that Medicare is paying, I think, $11,136, but the cost of their hips before we actually got involved over a period of a year approaches almost $20,000 on certain months. So basically, it was a loss for the hospital. and showing this statistic to surgeons, and then there's other slides we have here I didn't put in, but over a period of a year, these costs were all brought down to less than $11,000. So again, data drives change. Okay, and this is the most difficult area of change, of behavioral change in surgeons. How do you control surgeon access to your operating room in a responsible way? This is one particular surgeon in a hospital recently who is a very busy general surgeon who and we're showing this from actually Sunday through Saturday, but let's look at Monday through Friday. We can see that his Mondays and his Wednesdays and Fridays are exceptionally busy, and there is less but still significant busyness on Thursdays. With that kind of data and having the surgeon view that, and having the SSCC view that, we start to put this in a data form, and we can see this report card. And with this particular area that's circled in red, we're going to begin to allocate time to the surgeon that reflects his needs. You can see there's a lot of data here, but I'm going to show you this next slide here, which is even more powerful. The surgeon typically, for this particular surgeon, he had 4 8-hour blocks. And from our data intervention, and you can look at the slides in more detail later, but from our intervention and from our data, we suggested the following changes. First of all, we said your Mondays are fine. You need an 8-hour block, and we'll continue that. Tuesday, obviously, he didn't require a block or guaranteed access. On Wednesday, he had so much usage over the year that this data was collected that we suggested a 10-hour block. On Thursday, we suggested that he either have a 8 or 10-hour block, but every other week, not every week. And then Friday, we said an 8-hour block. When this was instituted, the surgeon basically moved right into this. It really didn't change his behavior, but the staff changes around these new blocks basically allowed for him to have a continuous and well-known staff that he could trust throughout the day. In other words, we weren't walking in on Wednesday and saying at 2 o'clock, "Could you please stay for another couple hours? This doctor needs to have your service." We actually changed nursing block to match his needs. So the fundamental issue here is that we are going to change surgeon behavior. Some surgeons lost their block, some surgeons had more block, some surgeons had less block, but we also changed the nursing and anesthesia staffing models to more correctly match the surgeon's needs. Once you start to have predictable days, you start to have a more satisfied staff, more satisfied surgeons. And we also engineered by this new block system a lot of the last-minute add-ons that surgeons typically put into their daily schedule, and we eliminated almost all the stacking that occurred in the middle of the night. We improved and decreased dramatically weekend demands, and so overall, doing this type of data-driven access revision dramatically improved everybody's satisfaction and also the efficiency and productivity of the operating room. I think we should talk a little bit about proactive schedule management, and we did talk about the huddle. I think this slide's a little bit out of order here, but the classic operating room is typically a last-minute, low-value operation. Everybody's kind of in a very disruptive state, usually most of the day, because of add-ons are coming in and a lot of people are being asked to stay, a lot of inefficiencies and lack of productivity. But a very proactive schedule management effectively replaces the traditional system, and it takes, as we said before, a new leadership model, a much more collaborative management system between anesthesia and nursing, and finally a complete review and revision of your processes to a more efficient, productive, and high-quality state. I think that's it. I'll get to the last slide here. And do we have any questions?
Thank you, Dr. Blasco. Yes, we have time to take questions from our attendees. The first question, with these scorecards, Do you have physicians initially who are somewhat resistant to seeing their productivity, first-time starts, and hard data?
In a word, yes. Nobody likes to see a report card, especially published for general review. So our process is one where we keep it relatively private initially. We let each surgeon begin to look at his or her report card, and then we begin to suggest some of the changes that should occur. And then as we move forward, these report cards become more open and general as we get things corrected in a positive way. But there's always issues where some surgeons are very resistant to any kind of behavioral change or expectation. But it's the peer intervention, and we said this before, the peer intervention between their surgeon peers that starts to bring about significant change. Yes, there's resistance, but remember, these implementations take 6 months or so, and over a 6-month period of time, this resistance becomes somewhat internalized, and we have a overall behavioral change that occurs within surgical organizations that's pretty positive. So.
Excellent, thank you. We have a question from Denise. What does closing the schedule mean at your organization?
There's two definitions of closing. The traditional close that many would like to see implemented is that it's a hard close. That basically, if an operating room is closed, let's say at 3 o'clock, and a surgeon schedules 3 or 4 cases, and the last case would run past the 3 o'clock closure, that particular case would be not allowed to occur, and we'd ask the surgeon to reschedule the case for some later date where he could fit it into that. That's a hard closure. That's can't be done in today's market because cases are too valuable to basically drive care away or to drive surgeons' dissatisfaction to the point where they look elsewhere to do their cases. So there's a number of methods of handling this. First of all, no case should be turned away without careful intervention by the operational leadership team. For example, the huddle should address these issues days before the actual day of surgery to alert staff to make staffing changes if that's necessary. The second most important thing is you redesign surgeon access that better reflects their needs. In other words, if you have an operating room, prime time is no longer 8 to 3 o'clock or 7:30 to 3 o'clock or 3:30. Prime time is the time that's required to have your operating room open to serve your surgeon's elective needs plus a reasonable number of urgent emergent add-ons. So first of all, hard closure is tantamount to driving business away. And secondly, you should have the daily huddle start to address some of these issues. And third, and most importantly, you should redesign surgeon access so that the hard closure issues don't really surface as much as they would with a traditional system.
Okay.
I would like to say one other thing. The classic prime time for the U.S. hospital has been in the day. It's usually between 7:30 and 3 or 7:30 and 5. But what we're finding now is that most hospitals actually have a second startup time between the hours of, let's say, 2 p.m. and 7 p.m. at night. And a lot of hospital operators are now adapting to that second period of access with staffing models that address those needs. Thank you.
Okay, very good. Thank you, Dr. Blasco. We have a question from Karen. How do you get buy-in from the anesthesia department when they are contracted service and not employees?
Well, first of all, whether they're contracted or employees doesn't make it. That's not as important as a significant thing. Buying an anesthesiologist or employing an anesthesiologist, for that matter, employing surgeons, really doesn't improve what you're talking about. In other words, having anesthesia step up and take a collaborative role in managing day-to-day operations. It's one of the most interesting things I've had to deal with in my career and in my practice There are anesthesiologists that really are interested in taking a more of a leadership role and getting involved with day-to-day operational management. The vast majority, I think, are more interested in providing good patient care. It's identifying leadership, first of all, people that can do that. And sometimes it's not the chairman. Sometimes it's other members of the staff. Some hospitals, the CRNAs take a leadership role. It's relatively a small percentage, but we've been in hospitals like that. I'm at a hospital like that right now. But how do you get anesthesiologists in particular to stand up and start assisting the nursing? And the key issue here is the leadership model that we've discussed, the Surgical Service Executive Committee. I, as an anesthesiologist, learned long ago that if I was involved with a problem issue, let's say a surgeon abusing the schedule or whatever, an inappropriate add-on at an inappropriate time, I found very early that I had no support if I did an intervention with the surgeon. And the typical surgeon response would be to do the runaround. He would run up to the administration and complain that anesthesia was preventing him from working, and I basically learned after a period of time I was not going to get involved with these situations if I did not have support of the administration. So with the new leadership model, where you have senior administration, nursing, anesthesia, and especially surgeon leadership, these interventions can now occur with the support of and guidance of the SSCC. And anesthesia, in most cases, is a lot more willing to get involved with collaborating with nursing leadership and managing the operative schedule. But the leadership model is of key and crucial importance in allowing this to occur. And the second thing is finding anesthesiologists and nurse anesthetists that are willing to step into this leadership role.
Okay. Another question from Nicole. Does your committee address individual surgeons that chronically overbook, causing overtime?
Well, there's two issues there. I'll give you some examples. It's always good to have an example. I'm doing this right now. We have a podiatrist at a hospital I'm working at right now who likes to start about 2 p.m. in the afternoon and work till midnight. Okay, and it's every Thursday. It was never addressed. I mean, it was a very significant dissatisfier for everybody. Trying to staff this person doing elective podiatry in a hospital operating room, not even an ASC, in a hospital operating room, was incredibly disruptive. The first agenda item out of the SSCC was basically to tell this particular surgeon that he was going to have to work during the daytime, start at a reasonable time in the morning, 7:30, and he would get 8 hours of block, and that's it, or move on. And because it was too disruptive, both financially and from a staffing perspective, to have him continue this way. So having surgeon peers make these decisions that would otherwise the hospital leadership would be very would not be the courage that would be required by hospital leadership to basically tell this guy that it was not there before this committee started. So managing surgeon access has to be a peer-to-peer thing, and it has to be driven by reasonable data and numbers, and then a reasonable approach. You're always going to get surgeons. If you don't manage your access, you're going to have all these outliers there, and creating some structure and some expectations and accountability changes surgeon behavior dramatically. I often joke that Surgical Directions is an organization that's founded on the principle that we change surgeon behavior and expectations, and we do it effectively without. In fact, most of our hospitals have a significant improvement in volume once we start to implement the structure approach.
Okay, thank you. We have time for one last question. Do you include case cancellations on the surgeon scorecard?
Yes, absolutely. And we do it from a couple of perspectives. I think there's cancellations and there's cancellations. A number, if you don't have a well-managed operating room, surgeons will book cases without regards to the patient's readiness for surgery, and then cancel at last minute without much intervention of any kind. When you start to have a system that's driven by data that basically suggests that surgeon XYZ his excessive number of cancellations, for whatever reason, that type of data and those types of analytics really change surgeons' behavior and expectations, and also affects how the surgeon's office books cases. We find that for most of our interventions, last-minute booking of surgical cases in a hospital operating room is relatively common. When we begin to put in expectations and structure and begin to publish data on patient cancellations and delays and turnover times, we find the office staffs respond very appropriately and very positively.
Okay, thank you, Dr. Blasco. And with that, we must conclude today's program. This session has been recorded. You may access the recorded archive by using the same logon information you used for today's live webinar. Feel free to share the recording link with your colleagues. On behalf of OR Manager, thank you again to Surgical Directions, our speaker, and of course, all of today's participants. Have a good afternoon. You may now disconnect.